Well, Dr. Kohli, thanks for joining me today. You're in Boston today, and as I said, I'll kind of start us over again. My name is Kevin Richardson, and I'm joined today with Dr. Kohli. I am the president of SolaTherapy, and we're really excited to launch this new product into the market, and specifically for pelvic floor myalgia and the treatment of pelvic pain, muscle, and spasm. And we've got one of our earliest users, Dr. Kohli, with us today. He's out of Boston. So, Dr. Kohli, as we kind of start, would you just tell us a little bit about your practice itself and the kind of patients that you see? And we'll go into pelvic pain a little bit, but would love to hear a little bit about your background and your practice.
Sure. So I'm a fellowship-trained urogynecologist. I did a full residency in obstetrics and gynecology, and then really had a passion for pelvic surgery. So I did a fellowship in Cincinnati. And then I came back to Boston, and really the first 15 years of my practice were all academic. So I was at Beth Israel Hospital, Mount Auburn Hospital, and then I had the pleasure and the privilege to be and found the Division of Urogynecology at Brigham and Women's Hospital. So it was really an academic practice. I did that for 10 years as division chief there, concentrating mostly on basic bread and butter urogynecology, incontinence, prolapse, overactive bladder. And then over the last 10 years, I've been medical director at Boston Urogyne, which is a private practice, and we've really expanded our reach into pelvic floor dysfunction. And we're dealing with all types of pelvic pain now. We're dealing with mesh complications. We're dealing with a variety of different conditions, including fecal incontinence, well beyond kind of the traditional urogynecology.
Excellent. Thank you so much. What a fantastic background. I mean, very involved in the academic world for quite some time. Did you do much pelvic pain in the academic world, or was that more when you moved your practice into private practice?
So I think what's happened in the last 10 years is two interesting phenomena. As we've gotten more experience doing pelvic floor as a urogynecologist, we've realized that pelvic pain is often a neglected and overlooked subspecialty or condition. And so there are lots of organs in the pelvic floor, including the bowel, the bladder, the pelvic muscles, the pelvic reproductive organs. And we're so compartmentalized in medicine that a lot of our patients felt that they were being shuttled from doctor to doctor to doctor with little communication and coordination. So that was one thing that drew us. The other thing what's happened in the last 10 years is with our use of vaginal meshes, this has increased pelvic pain in women. So lots of women had pelvic pain secondary to mesh complications. And as we got deeper into those issues and treating those patients, we realized that there were some very common pathways in all types of pelvic pain, including pudendal neuralgia, interstitial cystitis, primary vaginismus, vulvodynia, a variety of different pelvic pains, which oftentimes are overlooked.
So tell me a little bit in your own words about the type of women and the patients that you see in your practice that are suffering from this condition. Tell me what you see in your patient base.
So surprisingly, you'd think that some of these conditions are just conditions of aging women related to menopause and trauma and childbirth and surgery, but we really see women of all ages, of all types, complaining of various different types of pain. And we briefly kind of categorize it as either chronic pelvic pain, meaning constant pain, or provoked pelvic pain, that which may be worse during certain activities, whether it be exercise or sexual intercourse.
And so you see age groups from 20 and above. What age groups do you mostly see that have pelvic pain?
Yeah, I mean, they range from 20 years old to 90 years old. But the sweet spot probably is in the 40 to 60, 40 to 65 range.
And so how have you been typically treating these patients in the last 5 years? What is your typical algorithm of once you get a good differential diagnosis and you understand what you're dealing with, how do you kind of move forward?
So I think that's really the key, Kevin, is the diagnosis. I've seen a lot of patients, and I'm surprised and somewhat disappointed, where they've been given a label of a certain diagnosis for many years. And when you talk to them about the exam that they had or the testing that they had or how to confirm the diagnosis, many of them have really been honestly fallen short by the medical system. And so I think it's really important to listen to the patient, find out what her symptoms are, what are the precursors? Was it a trauma or an accident or a surgery or a certain event that may have caused it? What their symptoms are? And then doing a very, very detailed pelvic exam. And the vast majority of patients, based on symptoms and a detailed exam, you can really get a good sense of what's going on. And then some patients require diagnostic testing, whether it be bladder testing, cystoscopy, CAT scan. With pelvic pain, we're looking at a lot of the lower back. Some of these patients have lower back issues, herniated discs, Tarlov cysts, compression of the nerves, and people have just been treating them for their pelvic issues. So I think you have to really, really do a good comprehensive evaluation, listen to the patient, and do the testing that you need. Once you've made the diagnosis, I think it's much easier to help treat these patients.
So you went through a lot of things that kind of talked about how you make that differential diagnosis to come up with a chronic pelvic pain point, and you went through a couple different pain generators. So what do you think that main differentiator is? Is it tight and tender pelvic muscles, or is it something you can see under imaging?
Yeah, so I think there's no substitute for a pelvic exam. I mean, I always tell my patients, I treat a patient, I don't treat a test. Imaging can sometimes lead you astray because there are certain times we might find an abnormality, but whether or not that's actually causing the presenting symptoms, I think that's really important. So a detailed pelvic exam is really important. We're getting more and more an appreciation for the pelvic floor. So as most specialists, we really just concern ourselves with the end organ. So, the urologist handles the bladder, the gynecologist handles the uterus, the colorectal surgeon or the GI doctor handles the rectum. And the real question is, who's handling your pelvic floor? And so I think it's really great that in the last 10, 15 years, more and more pelvic floor PTs have come around. And I wish that education would spread to the physicians as well. But there's nothing more accurate than a finger. And so when you put your finger inside the vagina and you feel certain aspects of the muscles, and then if you've done thousands of these exams, you start to realize what's abnormal. So the same way when you're listening to a heart, sometimes you don't know what's normal or what's abnormal, but you know what's normal after you've heard enough normals, then you know what's abnormal. Right. And so in general, a pelvic exam, either at the opening of the vagina, in the mid-vagina, or deep in the vagina, shouldn't hurt. And so when we do a finger exam and we feel the muscles and the different muscle groups, we can really get a good sense of what's going on. So if they have unilateral pain on the exam, it may be a unilateral muscle problem, or it may actually be that the pelvic floor is out of alignment. So somebody slips on the ice, falls on their tuchus, and all of a sudden they have the muscle, and that's because the entire pelvic floor has shifted one way, creating tension on one side. If there's hypertrophy of the muscle or spasm of the pelvic floor muscle, they're going to have pelvic pain. So that single exam on the first visit is very key, and then we can use diagnostic testing to support it.
Excellent. Well, thank you very much for that. So when you get that diagnosis, over the last 5 or 10 years that you've been treating it, so how do you typically treat that patient? What kind of, is it an intervention? Is it medicine? Prior to SolaTherapy, what were you pacing your patients through as you progress them through different treatments?
So you always want to start conservative, right? So if there's dietary triggers or if there's physical activity triggers, whether it be exercise, biking, sexual activity, you want to work on those triggers first and see what's going on and be conservative. So trying to remove the triggers is probably our first treatment option. And then we will typically always start with medications or physical therapy. In the last 10 years, we've become big fans of vaginal suppositories, using muscle relaxants, using gabapentin, using lidocaine. I'm not a big fan of systemic drugs, only because it tends to cause a lot of side effects because of the oral first pass effect. I'm also not a huge fan of significant chronic medication, whether it be pain medication or neuromodulators, because in many cases, you're not treating the root cause. You're only basically blunting the pain response, and that's not a good long-term solution for patients. So once we figure that out, we'll generally do a multifaceted approach. We will try medications in the vagina. We might try oral medications. we'll try behavioral modification, we'll try pelvic floor physical therapy, and we really, really reserve surgery as a last resort for pain. And the reason being is most of the surgical procedures for pain are just not very successful, and we don't have a good way of diagnosing which patients will truly get benefit from surgery or not. And as a result, it becomes kind of a treatment of last resort for us.
Outside of your treatment with or your diagnosis with a pelvic exam, are there other diagnoses that your patients come to you with? Do some come with endometriosis, maybe they're post-LAPX or laparoscopic excision? They might have interstitial cystitis. Do you find that to be a component of those, or just something that is either primary or secondary to that original diagnosis?
So we're seeing a lot more pelvic pain patients only because kind of word has got out of some of the treatment options we're offering patients. So we see them ranging from endometriosis, interstitial cystitis, pudendal neuralgia, vulvodynia, vestibulodynia, dyspareunia. But I think the key, and I think the biggest thing that we have evolved over the last 5 years is that although those inherent conditions can be the basis of pain, almost 85% of those patients also have myofascial pelvic spasm pain. And so what happens is that when you have the woman who's got endometriosis, let's say, and she's got a 10 out of 10 pain, if the vast majority of her pain is related to endometriosis, she may respond to hormonal therapy or surgery for endometriosis ablation. But if the vast majority of her pain is related to myofascial, she's not going to respond. And I think that's why there's such variability amongst patients with these conditions, because very few doctors are looking at the myofascial component. And so what we do is we always do a pelvic exam. There are, on occasion, patients with these conditions who don't have significant myofascial trigger points. And if that's the case, then we won't necessarily do significant myofascial treatment. But like I said, about 85% of our patients, they do have myofascial pain. And when we treat that, they're getting treated for the pain.
How are you typically treating myofascial pain prior to SolaTherapy? I talked at the very first of the opening that our product is specifically related to myofascial pain, but before that, how were you treating them, and were you happy with the results or the effectiveness of that treatment?
So traditionally, the vast majority of people treat myofascial pain with pain medications and neuromodulators. And that's primarily because they're treating the pain as a component, not the myofascial muscle, because they haven't done a good pelvic exam. They don't know the diagnosis of myofascial. They don't know how to map trigger points. Once we do know that they have myofascial, traditionally, we've always had the option of giving oral muscle relaxants, similar to if you had a back spasm, you'd give them an oral muscle relaxant. Now we're doing more direct vaginal medication because it has less side effects and it affects the muscle more directly. And then the only other real option we had was pelvic floor physical therapy. And physical therapists who are well versed in pelvic floor can do a thing called myofascial release. And what they'll do is they'll massage the muscles. But in those patients who the muscles are too tight, it's really hard for them to do that without discomfort. It takes a long, long time, and 50% of patients just stop the physical therapy due to the discomfort. And it's a long haul. It takes a long time. And then up till about a year and a half ago, we were also using Botox. So Botox can relax the muscles and can work very effectively. There's two problems to Botox. Well, three. One is you have to be experienced in how to use it and the dosage to get the best effect. And that comes to the second two problems. One is it's oftentimes not covered by insurance. So if the patient's going to pay out of pocket, you want to make sure you're doing it right by them. Otherwise, they're not going to get an effect. And the third is sometimes Botox can cause urinary or fecal incontinence depending on the dosage and where it's injected, and patients don't necessarily appreciate that. But if you look at all these different conditions, all of them have a component of pelvic floor PT as a treatment plan. We've just found that SolaTherapy is a much more effective way of addressing the muscle than PT.
Well, thank you so much for kind of identifying the patient population that we've talked about, some of the treatments that you've gone through prior. And, I'm very excited to have you here because you are right now you do more patients than anyone else with SolaTherapy. And you've had some great patients experience that we've shared back and forth. I would love to hear a couple of your examples some of the patients you've treated with SolaTherapy and your just general thoughts on SolaTherapy and how it applies to pelvic floor muscle pain and spasm.
So we've been doing Sola since the beginning of the year. And when we first got SolaTherapy, I really wanted to try it out. And so what I did is I took some of the worst patients we had who didn't respond to anything else, and we offered them SolaTherapy on a complimentary basis. So we didn't want the pressure of the cost. We just wanted to study the modality and study it in some of the worst patients we had because, honestly, I didn't have anything else to offer them. And remarkably, we saw significant improvement. And I was, I'm always not a skeptic, but I'm a realist going into new technologies because at the end of the day, if I'm going to recommend them to my patients, I want to stand by them and know that they work. Now, every technology is not going to work for every patient, but we were, thoroughly impressed. I have no lack, I don't have any other words to describe how impressed we were with the response that our patients got. And the best part was, oftentimes when you get a good response, you have to put up with side effects, you have to put up with discomfort, inconvenience. The best part was that this therapy, it's 3 minutes, it's a gentle heat. The patients come in, they get the therapy, they walk out, there are no real restrictions. They do it 3 times a week for 3 weeks. And generally by session 5 or 6, we found significant improvement. Now, we've probably done about 25 patients to date. We have had no treatment failures in the sense that, we've had some patients who've shown 15% improvement and some people who've shown 90% improvement, but we haven't had any patient who's not shown an improvement. And what's really cool about the therapy is we are collecting, as you know, Kevin, the data on each patient with each visit. So at any given time, we can actually look back at our data and see what the response has been for our patients. And it's really helpful for them, too, because they have an app and they can see how they're doing. So far, touch wood, we haven't had a treatment failure. And I think part of that speaks to the fact that we're picking and choosing the right patients. Now, if we examine you and we feel like you're not a candidate for SOLA, we're going to tell you that.
Right. Right. So what Dr. Kohli is describing is our treatment algorithm is it's about a 3 to 5 minute treatment. You're in the office for about 10, 12 minutes, and we do that about 9 times. So 3 times over 3 weeks is a typical treatment algorithm. And so with that, we're getting those responses. It's a painless infrared light. So if I can describe that really quickly, is that we use near infrared light waves of 980, 810 to 980. That's the mechanism of action. So it passes through the vaginal epithelium into the pelvic floor wall, and that's where we excite the mitochondria with this near infrared light. It induces a process called photobiomodulation. And to say this simply, there's more information on both our website and on the Instagram profile. But really, it becomes a vasodilator. We bring more blood to the pelvic floor. We bring more oxygen, and by bringing oxygen, that takes away the pain. It gets rid of some of the toxins that are building up there. And so it's that painless effect that Dr. Kohli is talking about, because we're not rigorously working the pelvic floor. We're simply passing a light wave over your pelvic floor and bathing that pelvic floor in near infrared light, and it induces this process called photobiomodulation in the muscle cells. Photobiomodulation was invented by NASA 30 years ago. We like to say we didn't invent photobiomodulation. Dr. Zipper, our founder, invented a way to get it to the pelvic floor. So that's what we're talking about when we talk about the therapy. Please visit SolaTherapy.com to find out more about the diagnosis piece and see how the data that Dr. Kohli is talking about applies to you. If you're a patient for Dr. Kohli or SolaTherapy somewhere, you will get a readout each visit to see how your pain scales are going. We actually take data, patient experience data, on 2 sexual functional pains and about 6 functional pains like sitting, walking, standing, urinating, or a bowel movement, to see how that pain is decreasing over time. So, Dr. Kohli, we appreciate the patients that you've done. Would you have a couple of patients in mind that you can talk about your experience with them and their experience with SolaTherapy?
Yeah, I mean, so one thing I would encourage, if anybody's interested in it, definitely go to the website. And most of the patient testimonials that are on the website are actually our live patients.
Right, right.
And so they were very, very happy to share their experience and hopefully help other patients as well. But we've really done a lot of patients with interstitial cystitis. We've done with pudendal neuralgia. I mean, any patient who has significant myofascial pain, we're really offering them SolaTherapy. And we haven't had one patient who's not been satisfied with it. We've got some patients currently who are only having 10 to 15% improvement, but they're early on in their therapy. And then what we generally find, again, by treatment 6, you're seeing a significant benefit. And Kevin, you talked about the treatment protocol being 3 weeks, 9 sessions over 3 weeks, 3 times a week.
Right.
For those patients who don't get as good of a response, we would extend that twice a week for 2 weeks. And again, we haven't had a treatment failure to date, but we've had a wide variety of patients, and they've returned to sexual activity. They've returned to a lot of their exercise and other activity as a result of SOLA.
Yeah, I think one of the interesting things that we don't get into some of the intimacy issues all the time on things like Instagram, but for our product specifically. But as we see a lot of patients, when we look at what the symptoms are that are coming in, dyspareunia or painful sex would be an intimacy type symptom. And we know that that makes relationships difficult when of course, there's pain with sex. And I think you've had a couple of experiences with your patients that have been able to return to sexual intimacy with their spouse, correct?
Yeah, and the other thing to understand is that a lot of times we think of some end organ symptoms as being unrelated to the pelvic floor. So overactive bladder or voiding dysfunction can oftentimes be related to spasms of the pelvic floor. And so we have a lot of patients who traditionally for overactive bladder are treated with anticholinergic medications. And yes, they can relax the bladder, but what do? They cause dry mouth. They cause dry vagina. They cause other side effects, constipation. And that causes a woman to drink more fluid. And so what we've anecdotally found is that as we relax the myofascial component of these patients, they're coming back and they're saying, "Oh, I'm sleeping through the night," or I'm not going to the bathroom as frequently, or I'm not leaking, or my voiding is better. So I think the key is we're using a very safe, natural technology to bring the pelvic floor back to steady state, as opposed to manipulate it using medications which have side effects. And potentially, you can't stay on these medications a long time.
Right.
Whereas we're rehabilitating the pelvic floor in a very natural state. And I think the natural extension is to then do physical therapy and continue to maintain your pelvic floor, use suppositories as needed. But the initial burst of getting the edge off and getting you on the road to recovery, we usually start with SOLA.
Well, and you mentioned something that we care about a lot at SolaTherapy, which is aftercare. So we have a brochure where we have an app-based program that helps you with that. Dr. Kohli mentioned an ongoing continuation of therapy called Sola Club that you can work through to continue that therapy over time when you're getting a good result and want to keep it. But the aftercare program for us is exciting. I mean, it talks about diet. It talks about relaxing the pelvic floor, learning how not just to do Kegels in a positive way, but to do what is sometimes called reverse Kegel, to learn how to take that hypertonic floor and get it more in normal tone so that you're not always clenched up. And then, of course, there's mindfulness, better sleeping skill sets. We have a book that we recommend for your diet. And there's a lot of things that you can do post-therapy to help maintain the great result you're getting with SolaTherapy.
And I think I just want to echo that, Kevin, in the sense that, this therapy in many ways is a magic bullet for many patients, but it's not the be all and end all. So I don't think any patient should think that I'm going to come in 3 weeks, have my therapy, and I'm going to be great for the rest of my life. So this is one of those places where it's a team effort. It's a multidisciplinary approach. I think you got to concentrate on pelvic floor relaxation. You got to concentrate on the triggers. You got to concentrate on diet. And then over time, you have more good days than bad days, and the muscle rehabilitates over time. I think a lot of these conditions can be cured, not necessarily treated, but I think it takes some time.
I mean, our goal with the doctors and providers that are using it and everyone else that is involved in the patient's really health is really about getting them back to function. As we all know, that when you start scoring pain in 6, 7, 8, or 9 out of 10, you start limiting your daily life, whether it's limiting some of your physical activity. Sitting is a big pain trigger, and not being able to work if you have an office job because you're constantly sitting. The idea is to get you down into that mild or no pain so that you can get back to your normal everyday activities with the mindset that says my lifestyle changes a little bit, but I'm no longer in pain, and now I can manage that as I learn how to strengthen and relax and manage that pelvic floor now that I've done a pretty painless procedure that gets them back to a very healthy lifestyle.
I think that's a good point, Kevin. I mean, in the sense that a lot of my patients won't tell you that they're 100% pain-free, but they will tell you that they're 100% more functional. And so even for some of my patients, 20, 30, 40% improvement in their pain is something that they've never seen with previous therapies. And it can, just that 40% improvement or 30% improvement can result in a huge, huge improvement in their quality of life.
Right, yeah. And that's a very exciting proposition for many patients that have been suffering with this. When you look at our data, we see that most of our patients right now have been suffering more than 4 years on average. And we know that we stopped counting at 4 years because it's just such a high number that it's not in that acute phase of 6 months to a year. So when you get over 4 years, we think most patients that we've seen so far are suffering 4 years plus. And to your point, the results that we're getting at your place are those type of patients that have been suffering for years.
Yeah, and part of it is that they just haven't had the proper diagnosis and the proper workup. So, and the other is that it's just easier to throw narcotics and pain medication at patients rather than actually take some time and get the root cause and try to work with them to rehabilitate back to functionality.
Right, right. Excellent. Well, Dr. Kohli, I appreciate your time going through your experience with pelvic pain, how you got involved, and then how you got involved with us here at SolaTherapy. Any final comments on the patient or to the patient that might be listening?
I just want to thank everybody for joining. I mean, to join on a Friday afternoon before the weekend, it's hot out there. So I really appreciate everybody taking some time out, and I look forward to doing this again and getting more data for you guys.
Excellent. Dr. Kohli is a Boston-based urogynecologist whose office is actually in Needham, correct?
Wellesley.
Wellesley, Needham, Wellesley area, out a little
Yep.
west of town. But if you're in that area, he's the urogynecologist to go see about many things gynecologically related. So
Kevin, I appreciate it. And I thank everybody for joining us.
Yeah, thank you for joining us, everyone. Again, if you want more information, feel free to go to our website, SolaTherapy.
Kevin, I just got one question that I thought I would just answer. So who in your staff administers the treatment? So in my staff, we have a wonderful PA, Kristen Shaw, and Kristen does all of our therapies. And I think it speaks to how easy it is, as well as the fact that she's just kind and compassionate. She spends a lot of time with the patients. So it's not a complex therapy. And the fact that, I mean, a medical assistant probably could do it, but in our practice, we really want to kind of establish a certain level of training. But it's a very, very safe therapy, and there's very little room for error, which oftentimes, I've been doing a lot on the pudendal forums, and sometimes people aren't getting good responses to blocks, and you don't know if you're not a responder or you just didn't get a good block done by somebody. In this case, the treatments are really very standardized, very consistent, and either you're going to respond or you're not going to respond. And the vast majority, if you choose the right patients, you're going to respond.
Right. Excellent. Well, thank you for answering that question. I missed that as it popped up, so thanks for catching that.
No worries.
Thank you, Dr. Kohli. I appreciate your time. Thanks, everybody, for joining us. Again, visit solatherapy.com, and there is a chat function there, so we can get you in touch with Dr. Kohli if you don't Google him and find his number. But again, his office is in Wellesley, Massachusetts, just a little bit west of Boston, and he'd be happy to see you for anything you might need. But thank you, Dr. Kohli.
Have a great day.
Thanks, everybody. Happy Friday. Be safe out there.
Take care.
Bye-bye.